Had a player went down in the scrum, couldn't feel his arms, couldn't feel his legs. I had absolutely no idea what to do. I've never felt less useful in all my life.
You mess up in an elite sport, that decision will haunt you for some time to come.
It is quite high stakes. People will talk within the club. You might have said that this is a 3-week injury. Coaches and athletes will want to be back yesterday. I just remember one guy coming in with a soleus low-grade tear, and I just remember him pulling up and tearing and just wondering, like, how come he has got injured doing something so low level?
So today we're going to be looking at the realities of working in elite level sport, exploring some of the misconceptions, challenges and clinical decision making in this area. So, Steve, thanks for coming on today.
Hey, no problem.
So today we're going to be looking at the realities of working in elite level sport and exploring some of the misconceptions, challenges and clinical decision making in this area. So, Steve, I wonder if you could start by giving us a bit of background about your roles and experience and the level of sport that you've been involved in.
Yeah, I worked during the Olympic and Paralympic program leading into Paris with the British Judo squad, which was great, working with men, women, the Paralympic side. And then before that, I spent 6 seasons working at Newcastle Falcons, which is now Newcastle Red Bull. They are a Premiership rugby team in rugby union. I was with the first team there, leading on a lot of the athlete profiling, a lot of the injury prevention stuff. And then I'm also involved with some work up at St George's Park, working with Perform up there with some of the footballers who are maybe out of contract. British Gymnastics occasionally go and tap into some of their events, and also occasionally with the ITF, that's the International Tennis Federation.
Awesome. So you got a good breadth then. You've seen a lot of different areas of elite sport then.
Yeah, there's been a fair bit. So I think rugby, and this is something I always ask and sort of advise people on really, is you might have a real passion for a certain sport. Rugby wasn't mine, judo wasn't mine, but I wanted to learn and kind of develop and see a lot of different injury ranges and different kind of things that maybe you wouldn't see typically in sort of a mainstream sport like football, for example, where it tends to be ankles, hamstrings, groins, maybe some stress fractures and things. But yeah, rugby, judo, you're getting big trauma injuries, lots of concussion. You even get kind of choking out is one way to win in judo as well. So again, it sort of opens up narratives and communications around, well, how do you manage somebody who has been put out? Do you follow normal concussion protocols? Do you go down other routes really? So yeah, it's been a really nice sort of blend of different positions as well. In rugby is also worth noting. So within football, most of them tend to do similar things. Obviously a centre half does something different to a fullback and a goalkeeper, but they all predominantly need to accelerate, decelerate, change direction, etc. In a rugby world, you have a real nice mixture of people in the pack on the front row, the second rows who are the jumping ones, and then obviously kind of the little ones who do a lot of the sort of scrum half and kicking roles, as well as wingers and things like that. So yeah, it does keep you a little bit more on your toes, makes it a little bit more exciting than just going, I'm just going to return a athlete back to football or an athlete back to rugby. Thinking about the position is really important.
Yeah, and that breadth of experience then is quite important, you would say, to get, don't just focus on one field, try and get as much variety as you can to help you on that journey through your career.
Yeah, definitely. And I think if I look back at my early days, I think what I did is I worked and just volunteered alongside somebody at a lower level rugby club for about 4 or 5 seasons, really, until I became kind of the lead physio there. And then also just volunteered at things. So obviously the LA Olympics are coming up. I volunteered at the London Olympics, and I've volunteered at the Glasgow and the Birmingham Commonwealth Games as well. So they're always nice opportunities to kind of get to know people, see things in amazing seats as well. If you're on the field of play and you have something like a pitchside qualification, it does open up possible doors for you to get into places where you wouldn't necessarily have been able to get to, even if you had the best seats in the house. There's nothing better than being actually kind of dug outside and amongst the sort of back room, changing rooms, all that kind of stuff, really.
Absolutely. No, I think that's some great advice there. And what was it that drew you into sport then? Why was it that you wanted to specialise in that area?
I mean, I think I've always been sporty, so I've probably got a little bit of angling towards it. So I played reasonable level, football, tennis. But then I think what a lot of people do is after they qualify as a physio, they generally feel like, I should go and do rotations, get a nice sort of background and a bit of a foundation to kind of build from. Although I didn't do rotations, I went straight into an MSK field. I worked for Connect Health, based in GP practices and things. And basically kind of did what you could within sort of 20 or 30-minute appointments, but I just became very frustrated with not being able to do a higher level of rehab, really be able to see the acute injuries, because it tended to be things that were quite chronic. There was a lot of pain management style conversations that would go on, which were great. But yeah, I really wanted to see acute injuries, see how they progressed, and then all that sort of latter stage rehab that actually you start to be quite creative to get them back. And also just the access that you have to players on a daily basis rather than just once and then be able to review them 3 weeks later for another 20 or 30 minutes. So I felt like it was something that we wasn't doing well enough, and I wanted to do better, and I wanted to upskill in it. And I just felt like it was a great opportunity to move into full-time sport.
So for you, it's not just that passion for sport; it's that the rewarding nature of being able to see people through that full journey and give them everything that they need to get to where they want to be. You feel is much more possible in sport.
Yeah, I think so, and I think it's probably a really good point that you pick on really, because I think what I thought when I went into working in sport is that if I didn't know all the answers, and I didn't deliver something that was this gourmet package, then it was a bit of a slant on me, really. But I think as I've become a bit more comfortable, a bit more confident, got a better backing, I've realised how much athletes in particular like you to ask questions about some of the things that they may be a little bit unsure of, or explain a certain judo technique that they're not confident with because it's going to add extra stress, or they feel soreness or whatever it is on there. So yeah, definitely that sort of building of relationships happens a lot better when you've got more access. You certainly feel like you're more of a family unit, more of a sort of a community when you're within a sports team. A little bit different sometimes individual sports, so some people are very just about themselves versus maybe a team sport where you've got everybody who's kind of clubbing together. So the mentalities are a little bit different. You can obviously kind of have some people who are competing for the same position that can have little one-upmanships and things that go on. But yeah, in an individual sport where there's maybe only one person per weight category who goes to an Olympics or a Commonwealths, there's a lot more kind of what can I do individually to get all those little 1%ers to give me an edge over the competition.
And so obviously that environment then that you're, as you use the word family unit, is almost like how you describe that, which is quite different to standard clinical practice. How else do you feel that sport is different from your standard clinic-based physiotherapy?
Yeah, and I think it's an interesting world when you've worked in elite sport and then you sort of almost work in and around sort of private clinics and things and try to pull the things that you know have been done really well. So I think definitely for me, testing of individuals is something where there's been a massive sort of shortfall. And what I mean by that is almost where people have got maybe some strength deficits or endurance deficits, or their ranges aren't quite as good, or there might be some things along the kind of kinetic chain that are maybe not quite as strong as they should be. We often are a bit blinded, I think, in NHS worlds, or certainly where we were, because we just didn't have access to quite as much testing kit. I always say that the best thing, that if I could have anything, would just be a handheld dynamometer. So something like an active force would be probably the easiest one to get. It gives you a nice reading when you push into it. It will compare your left to your right. You can monitor kind of progress over time, see if your strength programs are kind of having the impact that you want them to. But you could just go literally for like maximal repetitions and things if you wanted. But yeah, I think there's often in private practice, not all the time, but maybe a narrative along, oh, I'm going to get hands-on treatment and I'm going to get manual therapy. But actually sometimes if you are going to supplement that with some strengthening, some control work, then yeah, having numbers that back up your clinical reasoning is really important.
And so just to build on that then, how would you like to see that used more, do you feel? If you're a student or a new grad or just somebody going into clinic, how would you use that to get the best out of that with your patients?
Yeah, and I know that there's the classic kind of line, isn't there, of like, if you're not assessing, you're guessing. And I think if we aren't getting numbers and data that help not only to make decisions around where we're going to focus our interventions, treatments, or strengthening, or kind of stability, or whatever it may be that you're going to focus on, you're probably missing that critical point. So in terms of how that would look, I think what you should probably be doing realistically, let's say it's someone who has knee pain, as an absolute bare minimum, what we should be doing is looking at getting some sort of strength score for the knee extensors, so the quads, and then getting a score for the knee flexors, so the hamstrings, really, as a minimum. You can obviously then go into kind of wider muscle groups, calves, glutes, trunk, etc. But yeah, quite often what you'll find is even with some elite athletes, it's surprising how much of a difference there is between one side and another. You can have a dominant side, so obviously kind of that side will normally be a bit higher anyway. But yeah, certainly when you start looking at things like the amount of calf raises that someone can do when they're getting Achilles problems or repeated calf issues, and they can do 25 to 30 reps on one and they can do about 13 on the other, there's a clear disparity between the two. And if they haven't got the strength as a bare minimum, then yeah, they're going to be potentially a little bit susceptible to some issues.
Yeah, I think that's a really good point. It's something that you do see in the day in, day out of clinical practice, isn't it? Is that assessment happens, but it sometimes becomes almost a bit arbitrary of, I'm going to check your strength and give you a grade out of 5 because that's what we always do, but not really using that information. And as you say, being able to quantify that is so important because, as we know, our skills of it, discerning strength differences with manual muscle testing on obviously not as superior as using handheld dynamometry, and that's become much more accessible, I think, now for clinicians, hasn't it, to have inclinometers, dynamometers that can give you clear objective readings.
Yeah, definitely.
How about the MDT then? Because obviously when you're working in sport, you talk about that family unit, you've got the team, you've also got the wider medical staff around you. How does that work? How do you find that transition between that and clinical practice, and how do you negotiate that?
Yeah, and I think this is probably something that you never get prepared for at university, really, is to kind of have that real linked up process between coach, athlete, strength and conditioning, psych team, the director, all that stuff. So yeah, you do have to obviously have a much more linked up communication stream. So quite often what we'd have is in the morning, an MDT meeting every single day to try and give them an update on where players are at injury wise. Sometimes if someone's out for 6 months and they know that at 6 months they'll wash over them. But if someone's touch and go for the weekend, whether they're going to be available or not, there's some things that we need to try out probably earlier than ideally we would do, just to get a bit of a gauge in terms of where they're at and are they going to be involved in that game. And if they are they going to be on the bench? Are we going to limit the minutes? Are they going to start so we can control things a little bit better? But it's a really joined up process in sport. When you see it done well, it's really slick and it's really smooth. Everyone's on the same page. But on the flip to that, if your communication's not clear, if you aren't sticking with your decision, because that's something which happens quite a lot, coaches and athletes will want to be back yesterday. So sometimes what will happen is you will have people really pushing for them to get back. You might have said that this is a 3-week injury. It's coming up to the kind of second week and the athlete and the coaches are going, well, you're saying that you're doing really well in rehab, so let's have them for the weekend. But if you've said that it's going to be a 3-week injury and you've tested them, you've ticked everything off, and actually they're looking in a really good place and they could be involved, you could potentially bring it forward. But quite often you will be challenged on this time scale that you've given. I know that that's what you said, but what I'm going to try and do is just keep chipping off. And it's just really important to be really consistent from the off with where you're at. And just outline the risks potentially of re-injury if someone is decided to be put in earlier. Sometimes it's unavoidable. If there's a last game of the season, a cup final, a relegation dogfight, a chance to get into the Champions League or something, and people are willing to kind of put their bodies on the line earlier than you say, that's their decision. Sometimes we've in the past had to get people to sign kind of declaration forms and things to say this is against medical advice that you play, and it might end up with potential worsening of your injury, might end up with surgery, etc. But I think just being really open and clear with that is super important. And if I contrast that to the NHS, where you're very often in a clinic room managing everything yourself, there's only really you and the athlete, maybe some members of the family or a patient and their family who you're kind of trying to get an idea of. It's quite often you making the decisions, and it doesn't often get escalated unless you want to speak to the GP or potentially refer them on to A&E. And there might not be that same sort of connection where you can obviously kind of jump next door, knock on the door and have that kind of nice collaborative conversation with that other practitioner.
Yeah, and I suppose two of the things I'm really hearing from what you're saying there is the importance of your relationships with the players, the medical staff, the coaching staff, because if there's tension, if there's friction, if there's not a good relationship, those discussions are going to be incredibly difficult. And you've got to have authority and respect as well, and respect for the other people. And also accountability on your part there's so much more accountability. We're not saying, yeah, this could be 6 to 12 weeks, this could be 3 months, it will take as long as it takes. This is, you're accountable for decision making and sticking by that decision or dealing with the consequences from that as well.
Yeah, it's a really good point, because if I remember my head physio saying to me, basically, what you have to do in this world is get at least 90% of things absolutely spot on. So that might be the diagnosis, it might be the return date, it might be to make sure that they don't then break down 3 or 4 weeks after they return. But it is quite high stakes. People will talk within the club. You're absolutely right in terms of the relationships that you start to build in amongst the kind of little community that you're working in. It can be a great environment to work in if you've got people, coaches in particular, who are sort of taking your word, they trust you, they're going with it. But you'll also have some coaches who are maybe ex-players, they've been around the circuit for 20 years. They know how long a grade 1 ATFL sprain will take. And if you say it's going to be 4 weeks because you want to do everything with them, tick them off and be ultra safe, that's not going to wash. So they will push you and they will challenge you on things. I always think it's quite a nice thing to give yourself a little bit of flex if you possibly can. So almost if your timescales are, this might be an ATFL injury, usually it'd be maybe 1 to 3 weeks to return them, depending on how they progress and if they've ticked everything off. But if they have certain things that they haven't ticked off yet in their objective screening, if you like, then actually it might be kind of support, making sure that you bring that to the table to emphasize why this person may need an extra few days or an extra week.
Yeah, because the reality is in, like, say, the NHS or clinical practice, somebody doesn't like what you do something that makes them worse or aggravates them, or they're just not getting better, they just don't come back. And you don't get that feedback of how things have gone. You just don't see them again. You say, well, maybe they're better, maybe they're not. Who knows? Whereas you mess up in elite sport, that decision will haunt you, I imagine, for some time to come.
Yeah, definitely. And I think the additional thing that's on your side is that really what you should be doing is have eyes on that individual through their rehab. You know what treatment they've had every single day. If they've had it, you've kind of almost periodized things. You've kind of factored in enough recovery. But yeah, sometimes you don't know what they're going to go and do outside of your sessions. So sometimes you might be really closely monitoring how many meters and GPS things that they've done. But then they might just decide on the evening, you know what, sack that, I'm going to go for a jog and I'm going to go for some hill sprints or whatever it may be. And then they come in ridiculously tight the next day and you're kind of trying to work out why. So you've definitely got much more clarity in a sort of a sporting environment if you've got time. I think on the time thing, there's often a narrative that you've just got all the time in the world. And I was listening to one of the Manchester City physios talking the other day, and he was sort of saying, well, yeah, I have one player and I have them. And that's me. If it's a key gourmet player, I'm basically one-on-one with that player. Maximum I'll ever have is kind of 2. And his wife, I think, works in sort of NHS physio worlds as well. And sort of they have this narrative when they get home, him saying, oh, it's been a busy day. And she's like, how many people you seen? He's going, oh, I've seen 1. He's kind of listing off all these things that he's done with them and taking them here, there, everywhere. And she's seen maybe 25 patients in a day going, don't you dare tell me that you've been busy. But yeah, I think it depends on injury numbers. So that wasn't the world that I worked in. At times we had about 17 injured in the judo world between myself and the other physio. So we're managing all of their rehab. That was obviously a darker time, but there was a lot of people dripping in and out of rehab, in prehab, coming in and doing extras. And then within the rugby world, again, people are pretty beat up after every single game and you're trying to turn them around, even if there's not a kind of a pathology as such. But there's still that kind of emphasis on trying to get them back in a pretty short space of time.
Yeah, and so I suppose that leads us on. How do you build that? What principles do you use to guide you for a safe return to play? You know, how do you build that safe protocol with your athletes? I know you mentioned about outcome measures, but what are the other ingredients that go into your reasoning process so that you can say, yeah, I'm quite confident this is 3 weeks, this is 6 weeks, etc., etc.?
I mean, I think we will go through a pretty thorough assessment when we have someone who comes off with some sort of injury. We will then usually make a judgment based on what the structure is, what the grading is. We know roughly what the timescales are. We've grown to learn things like muscular tendinous junctions and kind of deep tendons and hamstrings can come back to bite you. So you need to add additional time onto some of these pathologies. Is a grade 2 muscle tear, that might be very different to a grade 2 kind of tendon or muscular tendinous junction tear. We've got the advantage that sometimes if it's not ultra clear, we can often image them. So quite often we'll send people off for MRIs to find out actually what is the exact grading based on a sports radiologist who's come back with the exact grading and what muscles are injured. And quite often that is super useful to take into those MDT meetings to say, look, this has been scanned, it's this injury. Because sometimes if you go, oh, it kind of presents somewhere between a grade 2 might be a low grade 2, but it might be a high grade 2 for something. And obviously, as we said, the tissue that's affected might be an issue. And then really what we do from there is we get a time scale. And then we just build back. So we work out exactly what the demands are within a normal training week. That might be GPS, which covers the distance, but the accelerations, the high speed meters, the decelerations, changes of direction, etc. We know where there's low, moderate and high intensity training, so we can kind of drip them into some of the lower risk things. And we just kind of work back really. So we then go, right, well, in order for them to get into training, they need to be at this level of strength and control. And then we basically just work backwards to make sure that what we have as a target, to make sure we hit that, and then almost just sort of put a master plan together covering all the kind of key headings like stability, mobility, endurance, sort of amount of foot contact, impact work, how much running, what type of running, etc. that's needed. And that can vary, as I said before, sort of from different positions that an athlete plays in or how long they're going to play. All of that stuff should be factored in. And then I think the key bit really is once they go back is that we don't just forget about them because someone else has dropped into the injury world. We make sure we keep an eye on them, make sure we do some little regular check-ins to make sure that they haven't dropped off with some of their markers and make sure that they don't forget about all the things that they've done that's made them a bit more robust, because it's very easy once they're back in training just to go, right, I'll turn up for training, do a bit of a warm-up, do the training, head back home and just forget about all those extra either long endurance isometric holds or kind of specific strength in certain ranges, etc.
Yeah, and it obviously sounds like a really comprehensive process there. Do things get missed? Is it common that things will not go according to plan, or normally is it generally quite a well-oiled machine, do you find?
I think because we've got eyes on them a little bit more, you have a really good idea in terms of where they're at, both physically and psychologically. So I think sometimes what we'll do is just literally go, or what I've tried to do certainly with someone who's in rehab for a little bit longer, is just get them out of that medical room, either go for a walk with them or go for a coffee, whatever they prefer, and just get a bit of a flavour in terms of where that they feel that they're at, where they feel like they maybe are a little bit more vulnerable, what they feel like they need a little bit more of. And then we often would do almost like a formal psychological insight, really. It often gets done for ACLs, but we had just adapted that for different injuries that they have. And you get a bit of a measure in terms of things like what is their worry around re-injury, how ready do they feel to go back to training, back into matches, do they feel like they're sort of at risk, etc., etc. So yeah, I think there's obviously times when things don't go right. I had just writing a little calf injury blog on the weekend there, and I just remember one guy coming in with a soleus low grade tear. It'd been about a week, you hadn't felt it for 4 days, so we just went, well, let's go and do a little gentle jog around the pitch and then we'll do some footwork things outside. And I just remember him pulling up and tearing and just wondering, like, well, all he's done is plodded around this pitch. How come he has got injured doing something so low level? But then when you start to kind of learn a little bit more about the forces and the load of kind of 10 to 12 times body weight force going through it, even at low speeds, it's no wonder that if something has a tear in it and you put that sort of force requirement through it, that it may well tear. But again, you just learn as you go along. Sometimes things, when they go well, you reflect on and go, well, I wonder why that went well. If it doesn't go well, again, have a little look. What could you have done a little bit better?
Absolutely, yeah. And how do you manage that risk then? You know, we're talking about your red flag pathology. As we said, it's a very pressured environment. In terms of seeing those most serious pathologies, is that something that happens quite frequently, or is it something that's generally quite contained because of the environment?
I mean, there's always a risk of just being quite complacent. I think when you're with athletes and they're all healthy and there's not really many comorbidities that go on, that you kind of skim through some of the subjective history with some people. My advice would be don't, particularly if you're new to starting with a team or you're not sure of backgrounds. In terms of some of the red flag pathologies that we've seen. We've had DVTs in athletes who are ridiculously fit. So you just wonder, how have they developed a DVT? It was something that they were describing sort of in the calf, had a tightness. They thought it might be a tear. It wasn't particularly sore on any of the sort of normal typical testing things, but it carried on going, and it just felt like it wasn't fitting a true musculoskeletal pattern. So the doctor at the time actually said, there's nothing going on locally. It has to be your back that's referring. So I remember she MRI'd the back. The back showed that there was absolutely nothing going on. There was no nerve compression at all. And then it wasn't until we sent them for an ultrasound scan that you went, oh, wow, there's like a massive, great big blood clot that's sitting in there. And that explains why there's some additional swelling and things that potentially are going on that the athlete had reported, but by the time they came into the clinic, it had kind of settled back down again. So yeah, I think it's always worth just having that little hat on, that it's not always an MSK diagnosis. We've had an athlete present with testicular cancer. Again, he'd found a lump in his testicle, so it was sort of, well, any lumps and bumps need to go off for relevant investigation. That was a bit more straightforward. There's obviously kind of stress fractures that we get as well. So I think sometimes with the training load, you can have a stress reaction, you can have a stress fracture that can obviously develop into a more serious fracture from there. So again, those things just to pick up early, that this doesn't sound like an overuse medial tibial syndrome really. This is much more bony related, and just managing that appropriately. But yeah, I think getting on top of them early, referring on to someone who's in the right place to make that decision and that right investigation as soon as you can, really.
Yeah, and I think really highlights the importance of your physiology. It's something that we overlook sometimes from all everything you've spoken about, healing time frames, different conditions. Physiology knowledge is so important and really underpins all of that. And I think, again, that sometimes there's a bit of complacency within sports, that you're not going to see all these major red flags that we see in the NHS or FCP, but it highlights that those things still exist, and you're just as much risk of missing them in a sporting context as you are elsewhere. Do you find that as well, the subjective exam, you mentioned about the importance of that being really thorough? Is that challenging sometimes? I'm just thinking, when I'm working in a clinic, a new patient comes in, they expect to sit and talk to you for at least 5 to 10 minutes, maybe 20 minutes or whatever. When you're around athletes all the time, I imagine it is easy to cut corners with that, because you're engaged in dialogue with them already, you've chatted to them already. Is it hard sometimes to bring them back and say, look, I need to ask you some more specific questions?
Yeah, and I think it definitely can. I mean, most of the time the athletes are fairly comfortable going, calf's a little bit tight, it's just built up after the training session, I just need a little bit of a release here, there. But yeah, if there's some things that are a little bit more sensitive, or people have got a sort of past medical history that we're aware of, or a past injury history that we need to kind of go, well, actually, we need to delve into this a little bit more to find out, is it related to anything that's underlying? Then quite often what we'll have is a separate office that we can do that in. That would normally be typically like the doctor's office. But yeah, if the doctor's in there, then yeah, what we'll normally do is try and take them out of that environment to ask a little bit more. There's certain personalities, obviously, who are a little bit more animated than others, should we say, in a changing room environment. So you don't want to do your subjective necessarily with some of those onlooking eyes, because they'll want to be part of it, and they'll kind of throw their 2 pence in left, right and centre. But by and large, I think most of the time it's a pretty professional environment. You can always ask people to leave the room, do you know what I mean, if you're going through something a little bit more. But yeah, when we were in rugby, there was 4 beds, 3 physio beds, 1 masseuse, and they were always just packed full of people. So everyone knew what was going on with pretty much everybody. It's quite nice for a bit of camaraderie between the athletes. It certainly makes for, again, nice little stories that you realise what's going on in some of these athletes' lives, and can be a good laugh, to be fair. But yeah, totally take your point. Yeah, you want to obviously make sure that anything sensitive, look out for a better environment if you can.
Yeah, it sounds like your strength of character and authority are really, really key parts there, because you can be a fantastic physiotherapist, but you need to really be in control of that situation and be comfortable. I imagine, especially in rugby and some of those sports, say, right, we're going to go out here and have this conversation, or asking people to leave, things like that. So it's a skill, again, I feel like we don't necessarily prepare people for, but that ability to have authority and be in control of situations is really important from a dignity and professionalism as well as a safety perspective.
Yeah, and it is. I remember we brought in a Northern Irish lad to look after the senior academy, and he was quite fresh out of uni, quite a small guy, but he managed it brilliantly. He was just a real straight talking, straight to the point kind of guy, wouldn't accept any nonsense, and he just set the tone straight from the off that actually, you know what, I might be a bit younger or whatever, but actually I'm here to do a job and make sure that you guys are in the best place possible. And I think sometimes you have to sit down and almost just outline some kind of key ground rules and things that are there. You don't want to be too kind of fuddy-duddy and killjoyish, but I think you have to kind of almost set the tone and then stick with it. So it might just be little things like if people are late, we had some forfeits that go on for people who are late into the gym sessions, for example. If you book an appointment with the physio and they don't show up, again, it's another kind of tally on your mark. Or we used to have a wheel of misfortune with loads of kind of forfeits on that they'd spin this wheel if they missed it. And it was basically things that the athletes had come up with themselves, some obviously a lot worse than others in terms of forfeits. But I think just trying to find something that works within your environment, because there has to be implications for people who aren't maintaining those professional standards. And to be honest, I've always found that the coaches and the directors are always really behind us to make sure that it is a tight ship that's run, because that's going to give them the biggest opportunity to have the most players available for any particular time, really.
Yeah, and I really like that, because that collective responsibility, and it's about putting the responsibility back on them and saying, look, this is our time, it's valuable to us, it's valuable to you, and making sure that the athletes get the most out of what you've got to offer.
I've got a friend actually who was at Norwich Football Club, and they actually pull up contracts between them and the physio, and it might be that they need to do X amount of extra training on whatever injured body part it is per week, and part of that is also they need to do foam rolling for might be 10 minutes every single day on whatever area it is, but also it might be that's also contracted in there. If you do those things, you're entitled to some soft tissue release work from the masseuse for half an hour, whatever it may be. So you kind of create a little bit of a narrative. I used to quite like another colleague I worked with used to say, well, for every 5 minutes of manual therapy or treatment that I do, you owe me 15 minutes. On your own. So it was almost I'm happy to help support you, but this isn't a flop on the bed and this is the only input you have. If I do 15 minutes with you over the next kind of 24, 48 hours, you've got to build in half an hour of extra kind of self-directed work as well.
So no, I think you've given us a really good insight into the workings, the reasoning process, what the environment's like. What do you feel are some of the big misconceptions then that students or new graduates have, before going into sport? Because it's something we have a lot of people coming through. I want to go and work in sport. They're really passionate and that's really where they want to be. What are some of the misconceptions that they have about what that environment or that role might be like?
Yeah, I think it's probably sometimes worth just flipping it around the other way. So imagine that if they are a student and they've just qualified and they go into this environment, it's going to feel a little bit rabbit in headlights. Environmentally wise, it's totally different to a hospital setup where you've got a supervisor and all this sort of stuff who are going to be there to hold your hand and open the curtain you can ask a question to. I guess just imagine, do you feel like you are in a place that you're ready to deal with acute injuries, people coming off the pitch with concussions, maybe some kind of raging neural pain? Are you able to make those decisions in and around when someone is ready to return? And if I'm honest, I think the way that I did it was probably the way that worked best for me. So I spent about 6 or 7 years almost building a foundation, working entirely within an MSK world, did a master's, did quite a lot of work with sort of a lower level rugby club, as I say, before I then went into a professional setup. So the original rugby club I was at was in National League One. They trained on a Tuesday, they trained on a Thursday, and then they played anywhere in the country on the Saturday. And that was a nice little intro to it. I could work alongside another physio, so I could observe things that were going on. But quite often what you find is if you go into a role, you might well be a little bit sort of alienated. You won't necessarily have someone there that you can watch. I find with academy workers, they generally do insane hours. So if they want to learn a bit more or they want to develop their sort of keenness and get to see some of the first team or senior academy, then quite often what will happen is they have to come in at the same time that the first team would do, which is about 8 o'clock in the morning. And then they often don't finish until about 8 or 9 p.m. at night. So it's an exhausting time. The hours are incredibly long. you don't just sit around eating the finest steak that the chef's prepared unless you're in those kind of top Premiership clubs. There are obviously nice little perks once you get to that level, but I think the reality is you're probably going to take at least 10 years, I think, to get to a level where you're kind of anywhere near joining any of the sort of top elite clubs. So get experiences, whatever's available, whatever you're going to see quite a lot of things on. The size or the status of the club does not matter in terms of learning. So I would far rather be in a lower level club and learn way more than maybe go to a top club, not see very many injuries, just see this kind of 0.1% sort of world that's sort of so everyone's wrapped in cotton wool and kind of everything's super monitored. You're going to learn stuff grassroots wise. You're going to be able to trial things where there's not the repercussions that if you are in charge of the rehab of some marquee player and it doesn't go well and they break down, they get injured, they're not available. It doesn't matter as much at a lower level. Obviously, the person matters. So I'm not saying that the individual, we're not looking after them, but I think the pressures and the stresses that come.
The stakes are lower.
Yeah, exactly.
Yeah. How would, because I suppose my thought would that, I think that's a really interesting point you make about developing that foundation, because that's what I'm hearing as I'm going through, that you've got to be passionate about it, because it's a 24/7 thing almost. You're embedded in this team. You've got to be passionate about it, and you've got to have this underlying foundation of knowledge, which, no matter how good your undergraduate experience is, it's like driving a car. You don't really learn to be a physio until you get out on your own. What would your advice be then for those that are looking to do the grassroots stuff at the start, whether it's on the side or alongside other work, where they might be the only physio there, where it's is that an environment you would encourage people to try? Is it something that you think ideally you need to be alongside somebody, somewhere a lot of people are really passionate and want to go into that area, but it's doing it in a way that you're not just massaging somebody's calves with no clinical reasoning involved? What are your thoughts on that?
Yeah, I think that's a really good point, to be fair. And the way that I would kind of approach this really is just try and ask yourself, like, what sort of value am I putting on my time when I'm there? If you are going along, and even if you are volunteering or just an extra set of hands, which you often are in the early days, what kind of exposure are you getting? Are you able to kind of almost shadow the clinician who's teaching you things along the way? You're starting to learn and develop your skill sets in and around sports injury assessment and treatment and management, because sometimes people who volunteer are just shoved in a kind of old shower room that's kind of horrible. There's been a pop-up bed thrown because that's the only place you can be. You're on your own and basically just being told, well, just rub this part of the calf. And I don't think anyone really learns a great deal from doing that. Yes, you could argue you're starting to get a little bit of kind of familiarity with kind of soft tissues and things like that. But I think you're right. That kind of clinical reasoning, being able to observe what actually is going on, how much do you put a price on that? Because I think, yeah, if you did a year with a club, and you went maybe one Thursday night, for example, per week, and you just saw loads of different kind of injuries being triaged and assessed, and then you saw people's rehab, you'd start to see the context. I think sometimes at a lower level, you obviously don't get paid as much. There's often actually more responsibility because you are the only practitioner who's there, and it might be that you're there and there's 4 games going on a Sunday morning, which is like 88 players who are running around potentially getting injured, and you might not have the same amount of kit or facilities that someone who's in the Premiership does, where they've got paramedics on site, you've got doctors on site, you've even sometimes got surgeons on site, you've got nursing people on site. It's really weird because the higher you go, often the easier it is as a physio to then pass any of these difficult cases on to someone else who's better positioned, more familiar with kind of airway management or anything to do with kind of relocating joints or bones or whatever it may be, or spinal management. So yeah, it's a really weird kind of flipped way around. I think it's massively underpaid and undervalued. I know some of the courses that I've had to do in the past are now about £900 for a couple of days. So you do invest. I do think it's really worth investing in yourself, which would be a key message. So ask people what sorts of qualifications would be useful. Would it be useful to get massage? Would it be useful to get a run on pitch side trauma course qualification? Would it be useful to get an injury prevention, whatever it may be? It doesn't really answer the question perfectly, but I think definitely invest in yourself, definitely put a value on your time. And then, yeah, don't be afraid to kind of negotiate and step away from something if you feel like it's not the environment that is safe to go into as a sort of newly qualified practitioner.
And I would say that's really important for anybody who's, about to graduate or is thinking of going in that direction, that, you've got to be safe, because at the end of the day, there might be 80 odd players you're in charge of by yourself. But if something goes wrong, that's your problem. That's your fault. And saying, well, I had too much to deal with, I didn't have enough training, in the final analysis isn't going to be an excuse. So I suppose it's about being clear about what you can do, where your limits are, and making sure that you're practicing safely within that remit rather than trying to do everything and ended up getting it wrong.
Yeah, and I guess a prime example of that was me as a naive, few years qualified physio. Someone dropped out in terms of covering this rugby club. I remember I travelled all the way down to Newquay to play the Cornish Pirates, and I had a player who went down in the scrum, couldn't feel his arms bilaterally, couldn't feel his legs bilaterally, and I had absolutely no idea what to do. I didn't have a qualification. I just stepped in last minute, and I've never felt less useful in all my life. And it's actually really dangerous because it's outside of your scope. You haven't got the acute trauma skill set to manage this, and actually the repercussions could have been really, really bad. Luckily, the physio at the time for the other team took full control of the situation, but I was absolutely clueless at that time. I knew how to kind of tape a few ankles, maybe dish out some water or an ice bag, but again, it really hits home when you're in that environment how real and how severe some of the injuries can be, particularly if they're not managed correctly.
Yeah, that must be a terrifying situation to be in, and again, that authority and being able to step in and take control of situations which are an emergency. At the end of the day, there's perhaps some of those other red flags are low down the line. When you're dealing with contact sports, the risk of something serious is much higher. Steve, you've shared some absolutely fantastic stuff with us today. I really appreciate your time. Last couple of things from me, I suppose, if there were three sort of take homes for students, new graduates, or somebody who's looking to make that move into sport, what would you want them to leave this podcast knowing?
I suppose there's elements of what can you do to prepare yourself for that environment. So if you're going to go and step into that world and you're reaching out to people, be it on LinkedIn or social media or directly know a club near you, and you go and knock on the door the old-fashioned way, go in with a clear passion and demonstrate that you are passionate about it. And what have you done about it in terms of have you gone and sought extra CPD? Have you got some qualifications that they could use? But yeah, put yourself out there. Sometimes it is a voluntary role. I know some people will really value their own time, which is absolutely fine. I think the nature of sport, unfortunately, is that sometimes you don't get paid in the early stages until you take up a role, but putting yourself in that environment gives you the best chance. I think don't feel like once you qualify as a physio or a sports therapist that you are now ready for that environment. There's a big gulf between hospital care, as we've mentioned, and then going into sport. They're completely different worlds. I'd done 6 or 7 years, and I still felt completely out of my depth stepping into full-time sport. Some of the terminology and the processes I wasn't clear on. But I think there's never been more material available to people to do that upskilling. So yeah, put yourself out there. And also probably the last thing would be just what I said before, really. Just don't worry about where you are or what the prestige of the club is. Make sure you're in an environment that you're going to learn and develop.
And finally then, Steve, if people want to learn more, is there any resources or anything you're involved in at the moment that you'd want to share with people?
Yeah, I mean, I've just joined the faculty with the RFU on the Physis course. So I think that's the best of all the sort of pitch side courses that you can do. There's either a level 2 or a level 3, which are brilliant. I'd really recommend those. Obviously, that gives you the qualification. So it's within your scope of practice now, once you have that, to do that qual. I think the cheaper ones, I think about $350 from memory. So it's not cheap, but it lasts a couple of years to do. And the other things, I guess, if you're sort of just thinking about this or you're wondering sort of what it's like inside this environment, I've created an online platform called Grow Physio Academy. So at growphysioacademy.com, you can go on there, and it's almost tried to mimic the sports injury placement. I just remember we used to have hundreds every single year of requests to come in and spend time with us. We just couldn't accommodate it. So it basically is me videoed with athletes going through their journey through assessments, my favorite sort of rehab techniques that you can use. And there's also kind of online courses on acute trauma. So what we were talking about before, if you get a dislocation, a fracture, maybe someone isn't maintaining their airway, what you need to do, and all that sort of stuff will prepare you really, really well for the kind of qualifications and things that you need.
Amazing. That's great, Steve. I'll make sure there's links for all those in the description below. Steve, thank you for your time. I really appreciate it.
Well, thank you very much for having me. Been a pleasure.